Alright guys, so let's talk about the differences between myopia and hypermetropia or hyperopia as refractive errors and really the clinical significance behind this. So really when we talk about myopia and hypermetropia, these are refractive errors. Typically a patient or any of us normally should have a visual acuity of 6/6. Visual acuity is the basic. Visual acuity means the ability to see from afar, or really the ability to see from near. Basically when we're seeing from afar, this is normal, and whenever we have something close to us, like let's say a phone, our eyes will automatically change its refractive power, automatically to adjust its refractive power to be able to see near objects nearly. So not just distant, but nearly as well. And that's known as the accommodation reflex, where our eyes will converge. There will be convergence of the pupil, constriction of the pupil, and the power of the lens, like this one right here, it will get bigger. There will be contraction of the muscle. The ciliary or the suspensory ligaments or the ciliary zonules will basically relax, and this will get the biconvex structure of the lens to get bigger. And basically the idea behind this is that so that we're able to have more refractive power to our lens to be able to see nearly. Of course, with aging, by the time we're 40 or 50, we start to lose this ability compared to when we were children, where we have a high accommodation, and then at some point we'll need reading glasses. They call this presbyopia. But a pathological condition similar to it, where near objects can appear blurry, but distant objects appear normal, is hypermetropia or hyperopia. Okay? Now, these refractive errors, the problem with them is that you're not able to see clearly. True. But let's say you have an unstable refractive error. Then there can lead to a whole lot of problems. A lot of these refractive errors can be risk factors for a lot of things. That doesn't mean they will lead to it, but it's a risk factor regardless, associated with it. For example, in myopia patients, myopia are the opposite of hypermetropia, like me. I'm not able to see distant vision at all. But however, near vision, I'm fine. So I have to use my glasses, which are basically concave lenses that allow me to see distant vision, okay? So basically, let's say with myopia, for example, in myopia patients, if they have pathological myopia, high refractory error, there might be a risk of retinal detachment, for example. Let's say in the case of hypermetropia, you'll see in people with strabismus or squint, basically people whose eyeball is convergent towards this way right here, like accommodative esotropia. The children with very strong accommodation, they have a refractory error of hypermetropia. Okay. Also, patients of hypermetropia are at risk of amblyopia, and we'll discuss this in future videos, where they are at risk of visual deprivation of the eye. Hypermetropia is at higher risk. Also, a higher hypermetropia is also associated with a risk factor condition in certain glaucoma. For example, hypermetropia, narrow angle glaucoma. It can exacerbate acute attacks. While myopia is the opposite. It can be a risk factor for people like me in acute, not really acute, in open angle glaucoma. And we'll see in future videos what we mean by that. That doesn't mean that if you have myopia, you'll have all of these things, or if you have hypermetropia, you'll have all of these things, but it is an associated risk factor. There's a multitude of risk factors that can lead to these certain conditions. And also there are conditions too that can have irregular refractive errors. Take, for example, keratoconus, a degenerative condition in the cornea, where basically the cornea, instead of being hard and fixed and strong, it is protruding, conical shape, like this. Let's say this is a cross-sectional section. This is the cornea protruding outwards. This is known as keratoconus. Basically, there's thinning in the cornea at the center, and it gives a conical protrusion of the cornea as a result. And really, there's no specific etiology besides weakness in the actual structure of the cornea. And one associated risk factor was rubbing with the eyes. Constant rubbing of the eyes would lead to keratoconus as a possibility. And of course, people with keratoconus may present with myopic irregular astigmatism, all right? And we'll talk about that in a minute. So myopic irregular astigmatism, and therefore in that case, they would typically need surgery, by the way. They would need something to strengthen this cornea if detected early. They would use a corneal, basically what is known as a collagen cross-linking to strengthen the cornea, and it will give the patient hard contact lenses or glasses to correct this myopic astigmatism. So this is an example in keratoconus, let's say, the ones that have Manson sign when they look down, basically drooping of the lower eyelid when they look down. You can just search it up if you want, but this is one example of refractive error as well. Also, you can also have vision loss if you have degenerative condition. Like take for example, you can have basically loss of vision without refractory error. Like take for example, degenerative conditions such as pterygium. Let's say pterygium, or let's say for example pinguicula. Both of these conditions are degenerative conditions in the conjunctiva. The pterygium you'll see in pictures, they tend to be a wing shape. You tend to be a wing shape like this in the conjunctiva, basically like this picture, and you see a fibrovascular growth extending from the conjunctiva all the way to the cornea, and if it ever reaches the pupil, it will affect the central vision. This is without any refractory error as an example. So that doesn't necessarily, so the idea behind this is that just because patient has trouble in their vision or decrease in their visual acuity does not necessarily mean they have a refractive error. There might be something that could be obstructing it, okay? Like take for example the pterygium. If it ever reaches the pupil, this fibrovascular growth, as a result of degeneration in the conjunctiva, here we'll have to do surgery in that case, because otherwise we can basically do reassurance. And this typically is due to ultraviolet ray exposure, okay? The same idea with pinguicula. Again, conjunctival degeneration, but there's a yellowish lesion found in the conjunctiva itself, okay? So just one example, you can look at pictures of these two conditions. But this is just to give an idea that not everything has a refractive error with vision loss. So back to visual acuity, we have 6/6, or they say 20/20, okay? 20/20. Of course, when you have a decreased visual acuity, especially with myopia or hypermetropia, typically they give you prescription measurements, right? You sit in a device known as a phoropter, and they tell you to look at something like a Snelling chart or a near chart to read at, and then they will measure your vision besides that. So let's talk about the differences between myopia and hypermetropia. How do I know this is myopia? How do I know this is hypermetropia? Not just from the prescription, but also clinically. So from the prescription, typically they'll have a device called refractometer, where they automatically measure the refractive power of your eye. And they'll give you a paper that shows the S, C, and A. The S is the sphere of your eyeball. The C is your curvature of the eyeball, and the A is the angle. Where exactly is the problem? Or the axis, let's say, it's the axis. So the sphere, it has a positive or a negative. If you have, for example, a +2, then this refers to hypermetropia with the positive sign. If you have a negative sign in the S, this means you have myopia, -2. Okay? So this is one that interprets this is myopia or hypermetropia. Then you go to the curvature. The curvature could be positive or negative. Regardless, if there's positive or negative, it is astigmatism. There is uneven curvature of your cornea. And the axis will always be there. 180 degrees axis tell you where exactly is the problem. You have myopic astigmatism at 180 degrees. So the idea here is if you have a positive or a minus, regardless of the number at the C, or do you have an axis confirmed, one of these cases, especially the axis, if it's there, regardless of the C, it will confirm the patient has astigmatism. Like in keratoconus, you have myopic irregular astigmatism, okay? There is something to keep in mind in interpretation. So what is the problem in myopia and hypermetropia? Well, let's look one by one. In myopia, and we've seen its clinical significance, in myopia, the problem is that we have here a cross-sectional view of my eye. And in my eye, the problem is if you see the eyeball is a lot bigger compared to this eyeball. The axial diameter is larger. And the problem here is that the light, it will pass through the cornea, it will pass through the pupil, it will pass through the lens, all right? But the problem is that the light is going to be in front of the retina. This whole region right here, this is the retina. So the light here is in front of the retina. It's not measuring to reach the retina in time. That's why in distant vision, I have a fucking problem. I'm not able to see properly. Okay, so that's the problem with myopic patients. And that's why the treatment here is, well, we need to get this closer, right? So we'll use a concave lens like mine. We're going to use a concave lens where we will disperse these even closer. The opposite is in hypermetropia. The axial diameter of the eyeball is much shorter, and the problem is that the light around here, it's overshooting behind the retina. So you can see the light is literally overshooting behind the retina. So here the near vision is poor, but the distant vision is fine. Here I will do the opposite. I will not use a concave lens, I will use a convex lens that will basically make it one straight point that can reach at the retina, exactly at the retina. Alright, so I can use convex lenses to solve the problem. Okay? That's really the biggest difference between the two regarding the measurement, regarding the anatomical finding, and their treatment. Of course, they can be associated with certain conditions we mentioned before, esotropia or strabismus, retinal detachment, and so forth. We also mentioned the visual acuity and some conditions that have poor visual acuity, but that don't necessarily mean they have a refractive error. Okay? That's pretty much it, and thank you for listening.